So I'm just going to introduce myself for the people that are joining us via teleconference. My name is Dr. Wehner. I'm a family medicine OMN. Today we're going to talk about osteopathic approaches to constipation and bowel ileus. This is a presentation that I meant to give at the beginning of the month, right before we did the find and fix, kind of specific to this area that had some illness in our family. So today is going to be kind of a review related to that find and fix. So everybody who's there, you'll kind of hopefully make some more sense of everything that we went over kind of at the beginning of the month. So, so things to think about osteopathically when somebody's coming in or when we have consultations. Is it constipation versus obstipation versus an ileus? Can one of the third-year students maybe kind of just tell me what the difference is very quickly between the three?
How about 2 out of the 3?
Okay, go for it.
Constipation is actual fecal material is hardened and obstructing. Ileus is involved with peristalsis. You get decreased peristalsis, decreased impulse to the intestinal tract, and obstipation.
Obstipation is pain, like pain with pelvis. They're very painful.
An isthmus type.
I'm sorry?
Like it's an isthmus type reaction. Just with defecation.
Yeah, just with defecation. So, and we'll go over it a little bit more. So, first of all, functional constipation, the diagnostic criteria for this has to be 2 or more of the following. So, straining at least 25% of the time with defecation, lumpy or hard stools at least 25% of the time, sensation of incomplete evacuation 25% of the time, anorectal obstruction or blockage 25% of the time, and needing to use manual maneuvers such as digital evacuation or support, pushing on the abdomen, pushing on the pelvic floor for evacuation 25% of the time. Having fewer than 3 defecations per week, loose stools are rarely present without use of laxatives, and there's been insufficient evidence for them to have irritable bowel. Irritable bowel syndrome, the diagnostic criteria for that includes abdominal discomfort or pain with 2 or more of the following at least 25% of the time. They tend to have improvement with defecation. With constipation, they don't necessarily have that. Onset with change in frequency in the stool, so they usually tend to have a preference for either constipation or diarrhea, but they will kind of wax and wane between the two. And the onset is associated with change in the appearance of the stool itself. Again, there's usually no evidence of inflammatory, anatomic, metabolic, neoplastic processes that explain this. So most of these individuals end up getting a colonoscopy and having biopsies done that are all negative, and so that's how they get set up. So how does colonic muscular activity work? What affects it? Your sleep and wakefulness cycles, eating habits such as fiber, hydration, emotional status, contents within the colon itself, drugs, sympathetic nervous system, and the parasympathetic sacral outflow. So people who are chronically constipated tend to have a reduced peristalsis. We've talked several times in the PEDS lectures that we have in the morning that some kids, as they start to go through potty training and everything else, they will just kind of withhold. They'll withhold having bowel movements, and part of that is they say there's something that they can control. Well, they get this chronically constipated cycle that occurs, and then sometimes that can lead to just overall decreased peristalsis. So that's kind of why, this is an example of why we want to make sure that we kind of treat that in all of our populations. So sleep wakefulness cycles for those of us who are involved in hospital settings, we're waking our patients up at random times. They're not getting the rest that they potentially would at home if they were sleeping in their own bed. They're usually sick, so potentially their circadian rhythm might be off a little bit as well. So things just to keep in the back of your mind. Sympathetics, parasympathetics are individuals that come back having a big abdominal surgery or surgery of any kind. They're getting some type of drug to help with their pain control, which puts them at risk for problems with colon motility, as well as you just attacked several of their nerves as well in the nervous system. So potentially that just kind of is a double whammy, sets them up for ileus, for constipation, and problems going forward. So older people are 5 times more likely than younger people to develop constipation. Age alone is kind of a risk factor. So again, we talk about our elderly population in their 70s and 80s that come in and end up having some type of a surgery, and then they're on pain meds, and then they're on this, and they're on that. So, we see that a lot of those patients end up getting some type of stool softener or laxative or something to kind of help things along. And one simple thing that we can do is OMT. So treatments that we need to look at, especially for our hospitalized population, but in anybody that has this kind of a situation, is going to include adequate rest, increased fiber, decreasing stress, adjusting medications as necessary, or trying to improve pain without necessarily needing opiate use, and OMT. So obstipation is severe constipation resulting from obstruction of the intestines. It can be fecal impaction. It's usually painful to pass. And then ileus is a partial or complete non-mechanical blockage of the bowel, and that's usually due to a loss of the peristalsis. So postoperative bowel ileus is also known as postoperative gut dysmotility. It's the primary determinant of length of stay after abdominal surgery, and is thought to contribute to a ton of money every year. So there's good reason to try and catch it early and potentially treat in your preoperative and postoperative phases to prevent this from occurring. So general features include it being shortly after surgery, has electrical and muscular activity that gets affected. You have a lack of normal motility rather than an absence. And it will usually resolve within 4 to 5 days if treated. So again, just some general features. Pathogenesis is due to autonomic neural dysfunction. So again, you're disrupting tissues, and with that, the nervous system. And so that causes some changes in neural function, potentially decrease in electrical excitement of the gut itself, and decreased motility. Inflammatory mediators that occur with surgery, opiates, and gastrointestinal hormones that are released during the surgery. So the primary cause is due to sympathetic stimulation that is inhibitory, and the parasympathetic stimulation to the gut is also decreased. So what can we do about it? So there's been several studies out there that actually show that gum chewing tends to suppress the nociceptive responses and improve gut motility. So encouraging your patients preoperatively, postoperatively to chew gum sometimes can help with that. Additionally, if somebody has an ileus, chewing gum can help stimulate the gut. So you're not going to feed them during that process because things aren't moving. They're just going to end up with obstipation or something like that. So you're going to maybe try and get them to get the gut moving. So a lot of times they'll place an NG tube to cause decompression, but additionally this is another modality that we can use to try and help. Yeah.
Is it the mechanical act of moving the jaws of chewing, or is it because it's secondarily stimulating salivary gland that
It's
also?
both. So it's the act of actually chewing itself as well as the salivary secretions that come from it that help with gut motility.
I mean, can someone just eat meals, eat anything? Or are they just thinking they want something like, without eating, they can just chew gum and do the same thing, I guess?
Right, so a lot of times patients with an ileus, there's big concerns about actually feeding them until it seems to resolve. And so, you may give them ice chips or ice, and somebody that's with surgery might know a little bit better the protocol, but you usually don't want to feed those patients. They usually have an NG tube to decompress the stomach, and then additionally, if you can get their kind of gut motility working, which sometimes that can be through medications like Ritalin or this is another method that doesn't have any side effects really to it, which is kind of nice. Other treatments can be thoracic epidural local anesthetics, working on the parasympathetic and sympathetics and sympatholytics, such as the right gland, stuff like that, to help with GI motility. Laxatives, gum chewing, and we're here to talk about OMT today. So different treatment options that are out there. We usually encourage early ambulation in our patients. Early feeding when possible, like if before, if they're directly postoperatively, it's a good opportunity to kind of get the GI system moving if we can feed them as quickly as possible. Use of local anesthetics and epidurals decrease the amount of postoperative pain that most people have and the amount of opiate use that they need postoperatively as well. Like I said, NG tubes usually come into play if somebody has an illness. So OMT. The big targets for this are going to be lymphatic system, sympathetics, parasympathetics, and then the somatic system. In a study done, people that had OMT had significantly shorter length of stay than the treatment that had than the group that had no treatment at all. So we do a really good job here of consulting for postoperative things and getting OMT on board a little bit quicker, I think. A lot of it just kind of has to depend on what your facility has to offer and who's available. But I would encourage you as students, as long as you're talking to your preceptors, and residents, as long as you're talking to your attending preceptors as well, to talk them through, working on sympathetics, parasympathetics to improve some of these outcomes within your hospitals. So lymphatic and vascular system. The lymphatics from the colon travel within the mesentery. Tissue congestion interferes with removal of cellular waste and results in edema. Congestion increases stasis, fibrosis, and scarring, and drainage from the lower body usually occurs via the thoracic duct. So you guys remember the diagram in med school, you have the thoracic duct takes care of most of the lymphatic drainage, and then the heart and the lungs, they all come from the right side. Techniques for improving drainage of the lymphatic system are going to include the thoracic inlet release, the abdominal diaphragm release, the pelvic release, and the mesenteric release. So the first one is the thoracic inlet. Again, it's kind of, you can have the patient seated, they can be supine in the bed, and it's kind of that steering wheel approach. You're going to take the fascia either directly or indirectly in all three planes, so superior, inferior, side bending, and rotation. You can have them improve that tissue release by having them breathe in and out with it or using respiratory force. And you may need to repeat this 3 to 5 times until you feel the tissue release. Opening up the thoracic inlet opens up the thoracic duct itself and allows lymphatic flow to go unrestricted back to the heart. The abdominal diaphragm release is important because, again, it helps open up channels all the way back to the thoracic duct. And additionally, if somebody's going to have an abdominal surgery, doing this prior to and potentially post-operatively, depending on where their surgical incisions are, can be very helpful to allow lymphatics to flow appropriately. Again, you're going to place one hand on either side of the lower ribs, and you're going to just kind of contact down by using minimal compression. You're going to check flexion, extension, side bending, and rotation. You can either take it in a direct fashion, the way that the tissues like to go, or in a direct fashion, the way tissues don't like to go. And again, you can use respiratory force to help with that unwinding. Just continue to follow that movement either in an indirect or a direct fashion until you feel it completely release. With all of these, you want to make sure that you recheck after you treat it. Pelvic unwinding is done the exact same way. Again, you have your hands placed on the ASISs and applying some compression down through there. You're going to check flexion, extension of the pelvis as well as side bending and rotational forces, taking it either in a direct or an indirect manner to the barrier, and then allowing for unwinding. The alternate handhold that you can use for the pelvic diaphragm release is this one, and essentially you would, with your hand on top, you're kind of guiding the fascia to the point of ease, using respiratory force, and or you can actually have them do muscle energy type techniques with it. Myofascial is a combined technique, so you can have them point their toes up or flex their toes down toward the table, have them lift their legs till you feel that unwinding and that release.
How long would you plan on that taking, those 4 or those 3 areas, thoracic and then abdominal and pelvic?
No more than about 5 minutes. So the next one is going to be the abdominal mesentery release. Caveat to this, if somebody has a huge abdominal surgery, you definitely want to make sure that you're very cognizant of that, potentially not doing part of the release or staying as far away from that on either side as you can. You start at the umbilicus and you basically cup the tissues with your hands, kind of applying deeper pressure into the abdomen, and you're constantly moving your hands toward the umbilicus. So no matter where you are with this, you're going to be kind of pulling toward the umbilicus. So you start here at the small bowel, and you move toward the right upper quadrant because you're going to be coming directly below. So here's the umbilicus here. You're coming directly on the other side of it, kind of in this left lower quadrant, mid area. And you're going to be pulling toward the umbilicus here. Then after you come down, kind of to the right lower quadrant, you're going to take your hands and cup in and see if you can feel the ascending colon. And again, you're going to pull that toward the midline, toward that umbilicus as you're coming across. In this release, you actually notice that the transverse colon is not contacted. That's part of a different release. And so then you come to the inferior colon doing the same thing, pulling toward the umbilicus as you come, and then to finish, you're going to stop at the same colon. You want to hold each one of these for approximately 30 seconds as you're finding a release. And really, you don't have to go all the way. If you find an area of restriction, that's where you're definitely going to want to kind of cut that area and pull. Otherwise, just kind of work your way up along and then back down.
Question.
Yes.
Does it matter if you start at the beginning of the tube or end of the tube?
As far as clinical treatment, no. As far as it is introduced according to PLUM, which is the Foundations of Osteopathic Medicine, yes, because it's a different treatment. And you go the opposite direction, or whether you include the small intestines versus just doing a large colon and transverse and descending colon release. But currently, no. So abdominal massage was given to an experimental group versus no massage. Frequency of defecation, severity of constipation was measured, and there was significant improvement in frequency and severity in the group that was treated, even just with gentle abdominal massage. So even if you feel like I have no idea what I'm doing, or I'm not sure what I'm palpating, or I'm not sure how to really do this, just doing some gentle massage in that area along, the lateral sides of the abdomen is better than nothing at all. So I would challenge all of the surgeon, internal medicine individuals here to do that with their preoperative, postoperative patients to prevent bleeding. So the sympathetics for the gut. For the small intestine and for the large intestine, to kind of 3/4 of the way, the transverse colon is going to be T10, 11, and descending colon and rectum is T12 to L2. So increased sympathetic drive from somebody who's had surgery decreases peristalsis and can lead to constipation and ileus. It may lead to increased vascular tone, decreased O2 and nutrient delivery to tissues. And it also has an effect on the diameter of the lymphatic channels. So techniques to decrease sympathetic activity are going to include myofascial release, collateral ganglion release, and paraspinal inhibition. So for myofascial release, you're going to sit at the head of the patient, place your fingers posteriorly at the transverse processes of the spine, and position the vertebrae in a direction of ease. Allow for the fascia to unwind, so as things start to move, just follow that movement until you don't feel it anymore, then go back and reassess. The collateral ganglion release works really well if you don't have a midline incision. So anybody who has a surgical midline incision, this is not something that you can do with them. But to decrease sympathetic tone, you're just going to place your fingertips in a row above and below the umbilicus, applying some pressure posteriorly, and just holding there until you feel softening. So you're not moving the tissues necessarily, you're just kind of hanging out there. Paraspinal muscle inhibition. Again, same concept. You're going to take your fingertips in a row along the paraspinal musculature, wherever you feel areas of tension or tightness, and you're just going to apply some anterior pressure, and you're going to move those fingertips inferiorly. So you start at the head and work your way down, upper thoracics, work your way down through the lumbars, and treat both sides. Parasympathetics, so increased parasympathetics leads to increased peristalsis, glandular secretions leading to diarrhea. So you want to go to the point of having regular bowel movements without causing diarrhea. Parasympathetic hypoactivity leads to decreased bowel movements and glandular secretions. That kind of should make sense a little bit. So a good combination of both is kind of where you want to be for normal function. Hyperactivity of both systems can result in irritable bowel. So to normalize the parasympathetics, we're going to go through a suboccipital release, pelvic unwinding, and sacral rocking. So the OA is responsible for helping out with the vagal tone, right? So to kind of normalize the OA and the suboccipital region, you're just going to have the patient supine, place your hands parallel with your fingers just at the base of the skull. So you want to feel the occiput and then just slide your fingers down until you feel that space in between where you feel the musculature. And then you're just going to hold your fingers there. Some people kind of like to bring their elbows together, which brings their wrists laterally, and that will help kind of with some of that softening. So that's another thing that you can do to kind of help that with. Sacral rocking, this actually shows it in the prone position. However, our hospitalized patients, most of them are not going to be laying on their stomach. So you can also do this in the supine position by additionally just placing either one hand underneath if your hand is big enough. Mine's usually pretty small, so I usually put one hand under the sacral base and the other one at the sacral apex and rock back and forth between the two. You just want to do this until you're feeling good motion both at the base and at the apex. This tends to normalize both the sympathetics and the parasympathetics. So this is just, again, another study that showed that patients that had a rocking chair actually had fewer instances of Ileus because they were kind of providing that sacral rocking all by themselves. So interesting to think about. And at this time, I think I'm just going to open it up in case anybody has any questions.
I have a comment. With the OMM consult service, a lot of times, sometimes we're consulted like right away after surgery, say a long, say, abdominal surgery. Other times, it's like 5 or 6 days post-op and they still have an Ileus. And yes, the treatments you have up there, very nice, simple, everyone remembers them. And just I'd encourage the residents to, when you have that post-op patient, even in the post-op area, the room, before they go to the floor, just even to feel those paraspinal muscles and to see how they are in it. Because if you never feel anything, you won't be able to do anything. And so if you just run your hand down their back or feel their neck, they won't mind at all, and may speed the process up. So just an encouragement to do that.
Any other questions or comments? You know, when our patients go to surgery, they kind of get their head kind of hyperextended so that they can, intubate them, and then they usually get put in kind of weird, funky positions sometimes for a little while. So, even just kind of normalizing those things after they come out of the OR, either on the floor, first stage post-op, second stage post-op, whatever, or at least just being aware of those things, looking at the OA, just taking a peek at the sacrum and the lumbar spine and lower thoracic. It doesn't have to take long, but even just gentle massage in those areas, even if you feel like you're just not adequately equipped, will help in some way, shape, or form. So it is better than nothing. And so the challenge is just, in some ways, getting your attendings to get on board with it, and in other ways, to just practice it.
Also, they may say the patient likes it, they'll remember you when you come back in the room versus all the 20 other people they see. So, and they'll maybe ask you again to rub their back or get their neck, work on their neck. So it's a good thing.
Are there any other studies out there besides the one large study on OMM for treatment of after surgery? Has anything ever been done here at this institution, even looking retrospectively?
At like constipation, Ileus?
Yeah.
I don't think so. I know that there was a study recently that was talking about OMT findings and colonoscopy findings. So that's a relatively recent one that just is completed. I don't know that it's written up yet or that it's been submitted, but it is research that had been ongoing within the last 2 to 3 years. So it's definitely an area of need for further research. Anything else? Well, thank you so much for your attention and have a great day.